So what I started to say is I've chatted with Glenn, and he's heard about how my practice has changed over the last 4 or 5 years, and he just asked me to join your group tonight and share my story of how our practice transitioned from kind of an analog practice into a digital practice, and uh, maybe give you some insights on what a journey like that can look like. Um, Here we go. All right. So one of the things I want to be completely transparent about is that I lecture for Invisalign. I got to the point in my practice in doing a high share of chair of Invisalign, and they invited me to be on their faculty. So I do get paid to speak, but anybody that knows me will tell you right away that I'm a pretty straight shooter, and they don't uh, tell me what to say, and frankly sometimes I don't always agree with them, and so I'll point out those things when I think that maybe something could be done a little bit smoother, or I deviate from what their protocols are. But it's something I certainly want to be transparent about. As Mike was telling you, I did my dental training at Michigan, my ortho at Minnesota. I've been doing Invisalign treatments since 2000, back when it wasn't very much better than what we were doing with suck down retainers. And it's really morphed into a very sophisticated product now that I use. I wish I could use it exclusively, but I still have patients that come in and ask for brackets and wires. But it's taken on a much bigger role in my practice than I ever dreamed that it would. Um, I've been asked a year ago to teach at the University of Minnesota, and my primary role there is to teach the residents clear aligner therapy for patients. So I'm doing that kind of thing now as well. And I also have a very busy private practice. It's grown in the last 4 or 5 years from a 4-office practice to 5 doctors in 12 locations. So it's really taken a very unexpected rapid rise, and to tell you the truth, we're experiencing some growth pains because of that. But we'll talk about that as I go through the presentation. Besides work and teaching, I have a family, and I have 4 fantastic kids. I have a daughter that just started dental school in this fall, a son that's looking at dental hygiene and dental therapy, another daughter that's at Ohio going to college, and I'll forgive her someday, being a Michigan grad, that she's at Ohio, but I'll get over it. And then my youngest son wants nothing to do with teeth and is all about computers. And I keep telling him, you can do computer work and still deal with teeth, but I don't think he's going to go down that road. And then I'm married to a wonderful man who also happens to be an orthodontist. And he practices in a DSO setting, completely apart from my practice. But also does quite a bit of Invisalign. So yes, we do talk about aligner therapy sometimes at the dinner table, and it's a big chuckle in our family. But this slide really kind of sums up what I want to talk to you about tonight. Um, this is a sign that I saw at the Minneapolis airport. Has nothing to do with dentistry, but when I saw it, it really resonated with me and where I was at in my practice. We're going digital in orthodontics, and what I felt like around the year 2013 or so was that if I didn't make that transition, then I was going to be lost, and I was going to lose market share, lose revenues, and I really felt like our practice had to make a decision if we were going to go to the front of the pack and be leaders, or we would fall and not be nearly as successful. So here are some of my insights and kind of the backstory with what happened with our practice. In 2012, we were pretty complacent. We were doing okay. We were having single-digit growth every year. Occasionally, we'd have double-digit growth, and we were going along just fine. But in 2013, we had the first year that our revenues took a downward turn. And at the end of 2013, our practice accountant sat us down and said, okay, your revenues are down and we need you to start looking at your overhead because you're either going to take less money home, maybe cut some employees out of the payroll, or something, if this trend keeps going, is going to have to change. Now, that's not a very comfortable conversation to have. So we started looking at, rather than reining in and cutting back, what we could do to turn our practice around and regain the market share that we had been losing. And so the big question was, in a really saturated market like the Twin Cities is, where you have an orthodontist about every 2 miles in the city proper, how could we stand out from the crowd? And one of the things that we kept noticing was that as our numbers were going down, Invisalign's numbers were starting to really exponentially grow. And so we kept coming back to the question, was Invisalign the answer to differentiate our practice? And when I say our practice, I'm referring to this lovely woman here, Dr. Delarancho. She's been my business partner for about 22 years. And we asked each other over a few bottles of wine and some really deep conversations if we wanted to go down this road of choosing aligner therapy to differentiate our practice. And she's the one in the practice that holds kind of a tight purse string. So if we were going to do it, it had to make sense. And it had to make sense from a patient care standpoint, for quality of care, certainly. But also it had to make sense financially. And we kept coming up with these 4 key questions that we needed to answer. 1, did it make financial sense to grow our Invisalign base as part of our revenue generating for our practice? 2, if we decided we were going to, how did we go about doing it? And then 3, how was it going to change our day-to-day workflow in the office, and what would we have to change internally to do that? And then certainly, what types of treatment was Invisalign just as effective or better than fixed? And that's where we were going to focus. So the first question, how does it, or does it make sense to financially grow our Invisalign base? We had to look at profitability. And one of the things that we were scratching our heads about was we have a larger cost of entry with Invisalign because we have the lab fee. And so how does that play in with the profitability?
We split the difference between you and me. Each one of us pays 20.
So we looked at these two categories, efficiency and cash flow. So looking at the efficiency column, we knew that putting on a few attachments was much less time than doing a full bonding. We knew with efficiency, we would have fewer emergency appointments with Invisalign. We had seen that from the aligners that we were already doing. We were seeing our patients less often, and at this point we were seeing our aligner patients about every 10 weeks. And we knew when they came into the office that their typical appointment time wasn't taking up the whole appointment slot that we had allotted for a typical adjustment appointment. And then under the cash flow, We knew we could get the lab fee down if we increased our volume. And then we had already seen from some of the ramping up that we had done that we could incorporate more visits in our day without adding extra staff. And at this point in our practice time, our lab technician that we had full-time had decided that it was retirement time. And so we made the decision to not find another lab tech. And we started offering some discounts for pay in full to help with the cash flow. And another thing we realized is that unlike most of the bills in our practice that were due net 30 days, that our Invisalign lab fee wasn't due for 60 days. And that plays into how you can structure your down payment so that you're not asking for such a big amount right away, but you can space it out. So we started doing like a half of the down payment down when they signed the contract, the other half of the down payment when the aligners were delivered, so it wasn't such a big chunk of money to cover our lab fee all at once. So those are some things that we went back and forth and decided that we were going to give Invisalign a shot at growing our practice. So looking at the lab fee tiers for the increased volume discounts, Dahlia, my business partner, wanted to get up into the diamond level so that we were paying the least amount allowed for the aligners. So for about a 6-month period, we decided to just, for lack of a better phrase, take it on the chin and get to that level. And it was a little uncomfortable for that 6-month period, but we've never dropped below the top level since we got there. So that speaks for itself. And one of the things that we also agreed to do is to pull charts of fixed appliance patients and Invisalign patients and actually do some metrics on how much our brackets cost, our wires, how many appointments patients came into the office versus aligner patients, how often they came in, emergency appointments, our lab fee, and actually look at the data from pulling charts. And here is just an example of some of the things that we saw. Our typical fixed appliance patient who might have, say, a Mara or a Herbst or something like that, we typically would charge a little over $6,000. And between the brackets and lab fee for say, a class 2 appliance, we had an overhead of materials of about $500 or so. And our average fixed case might come in about 13 visits. And looking at that at a 30-minute chair time and doing the cost per visit and hourly, we came up with some numbers. And we looked at the same kind of things for Invisalign and found out that really the revenue per visit was a little bit better with Invisalign, but what really stunned us is how much more we were making per hour with Invisalign, because the typical Invisalign fit assessment appointment, really when you looked at the amount of minutes they were in the office, was about half of what an adjustment was. And that was a real eye-opener, because we realized at that point how much time we were wasting when we had a 30-minute or 40-minute adjustment appointment and we were still putting aligner patients in our same appointment scheduling template, okay? So one of the things that we agreed on before we started doing all these deep dives into what we were measuring is if we found out data that was important, we would actually change. We agreed that we wouldn't ignore it. And I think that's really important. Don't bother looking into it if you are not amenable to change, because it's a waste of everybody's time. So the next question we looked at is, okay, we've proven to ourselves that aligner therapy can be more profitable, even though you have a lab fee. So now how do we ramp that up? And looking at just some general statistics of how many people were in our area and how many people on average seek orthodontic care, we realize that there's a really large pool of people that are in need of care but don't come in. So why do they not come in? Well, maybe they don't want fixed appliance therapy. Maybe they don't want expanders. Maybe they don't want teeth pulled out. Maybe they want limited treatment. So one of the things that we also looked at is how we could be more consumer friendly so that we could offer a bigger variety of treatment options when people came in. And one of the people that helped us do this and came up with some really great ideas was our strategic account manager that we have through Invisalign. Her name's Tracy Weber. She's a rock star. I don't know where you are and who your reps are, but I know that they do a lot of idea sharing. And one of the things that we just had to make peace with was when someone like Tracy comes in and gives us a non-orthodontic traditional idea, is not to shoot it down right away. And just because we've never done it that way doesn't necessarily mean it's a bad idea. So Tracy was a little bit eye-opening for us, where she'd come in and say, well, have you ever considered doing X, Y, Z? And instead of just saying that won't work, we had to really step back and go, well, how could we incorporate that? That is maybe what the consumer wants, and how does that fit into our orthodontic practice? So we tried to make a kind of a partnership out of the resources that Align was offering and trying to make some changes in our practice. And I'll just kind of run through with you some of the things that we did. We actually raised our fixed fees and we lowered our Invisalign fees, because one of the stumbling blocks we noticed in our consultations with our parents saying yes to Invisalign, or even our adult patients saying yes to Invisalign, was that it cost a little bit more. So we actually raised our fees on fixed, lowered our Invisalign fees, and said, you know, here we're prescribing this, and if they asked about fixed, we said it's the same cost, and it took that barrier out of the conversation. One of the things also that we noticed as we started doing more aligner therapy is that we had this deluge of ClinChecks all of a sudden to look at. And like I said, I'm busy with a lot of things outside of work, and I didn't want to take that work home and do it in the evenings. So I started right away training one of our staff members to look at ClinChecks with me. And for probably 5 or 6 months, I had this particular staff person do every ClinCheck with me. Now what I do is I check the ClinChecks after they've been cleaned up by my ClinCheck coordinator. It saves a tremendous amount of time. And that is actually the person now that it was like my lab tech before. Okay, so that hat kind of changed. But I have this very important person that has a role in the office now that takes the raw ClinCheck, which I liken to a canvas with a sketch on it, and they make sure that my treatment plan was adhered to, that my clinical preferences have been implemented, and I get a ClinCheck that actually looks like it's had from a rough sketch to like the painting done, and then I put in the details, and it's really a tremendous time saver. The other thing that we did was offer a satisfaction guarantee to switch. So if I still had people that were a little bit on the fence between fixed or aligner therapy, I would say, well, it's not an irreversible choice, and we won't charge you if you get into it and decide that you would have preferred fixed appliances. And at that point, it's somewhat difficult for people to actually say no to trying it. We did measure how many people actually switch, and we measured both directions, braces to aligners, aligners to braces, because we do have some patients that have a lot of breakage, don't keep their teeth clean, and they actually end up taking the braces off and going into aligners. 1.2% of our patients make a switch. So it's really not a large percentage from a financial standpoint. In 2015, we started doing some direct mail advertising. And I have to give Dahlia credit for some of these very clever mail pieces that she developed. Her philosophy with developing these always was that the direct mail should start a conversation, not just a piece that's on the counter that says, hey, my office is better than your office down the street, come to me. It should be something clever. It should be something that's thought-provoking. And this is just an example of one of the pieces that we sent out. So, you know, just pointing out that the way to change your teeth, the way to straighten your teeth has changed. And we could envision this being picked up by a parent going, hey, you should see what I had to go through to get my teeth straightened. And maybe they have a laugh about it, but at least it got the attention versus your typical mail piece that would come. And in 2015, we started dabbling in social media as far as Facebook posts. And now, of course, you know, it's more about Instagram and things like that. And we've grown to the point now that we actually have a staff person that orchestrates these things, because frankly, I don't have the time and I don't have the intuition of how to be on social media. So we have someone that helps with that. And we also decided in 2015 that we would go to a completely one-step consult. What does that mean? That means that when they come in, they get a scan, they get x-rays, and they get their photos, and then they have their exam. So at the end of the consultation, everything is ready to go. We've presented options and we've presented financing. So if they decide that they're going to go ahead with treatment, they put a deposit down, and then we start working on the ClinCheck and move on from there. If for some reason they need to go home and think about it, we're not a high pressure sales at all. The only thing that we do, two things, and I'll talk about the second thing in a little bit more detail in a minute, but we tell them that their scan is accurate for approximately 2 weeks. And especially for kids and teens that are getting teeth in and whatnot, that's absolutely true. And even with adults, I don't want to go much past that without a fresh scan. So it's kind of a call to action not to leave it hanging for too long. And the other thing we do is we send an email follow-up letter with a picture of their simulation and their occlusogram, just to remind them what we talked about. And I'll show you an example of that in a minute. So at our consultation and their first visit to the office, we really wanted to focus on the patient experience. So that actually starts with a new patient phone call, not just coming in for the exam. It starts even before that. So we had to do some phone training because we were not very good about that at all at this point. We were adequate, but not stellar. So we've done a lot of phone training with our staff so that they will say, are you or is your daughter, your son, or whoever they're calling about interested in braces or Invisalign? So we plant that seed at the new phone call, and sometimes they'll say, oh, well, I don't think that Invisalign will work. And so that starts a conversation about, you know, our doctors have more experience than many of the doctors in the area with Invisalign. So we can certainly talk to you and let you know if that's an option. So it at least plants a seed. The other thing we ask about is what kind of lifestyle things is the person involved in? Are they in sports? Are they play a music instrument? Just a kind of casual conversation so that we might say something like, oh, well, hockey players really like wearing Invisalign because it doesn't interfere with wearing a mouth guard. So some things that we can say like that. We like to ask if anyone else in the family needs to be evaluated. And often a parent will say, well, I have another child too, but I don't think he's ready yet. So we can make the invitation to, well, you can go ahead and bring your other son into, doctor can just take a quick look and let you know. And then we always talk about the technology that we have. So you're going to be so excited at our office because you won't have to have a goopy impression. We have a 3D digital scanner, and that makes for a much more pleasant experience. So all these things that you can plant seeds at the new patient phone call so that when they come in, they're already thinking that your office is a little bit different than the average office. So let's say they look at your office and they're not calling on the phone right away. They look at your website. One of the things that I want to encourage you to do if you haven't recently updated your website is certainly to do that. It can't be a 6-7-year-old website. It needs to be hip and it needs to be up to date. And then one of the things that we're doing on our website is they can make appointments without calling for consultations. So they go on to the website, they can schedule a complimentary consultation with one of the treatment coordinators. And they can schedule a consultation with the orthodontist. Now, at first, I kind of made fun of this a little bit because I thought nobody would make an appointment without the doctor in the office. And I was really proven wrong. We have new patients come in every day when I'm not in the office and meet with the treatment coordinator. And what they do at that particular appointment, they can't take x-rays because that's Minnesota law, but they can take photos. They can give them a gross idea of the cost, and they can send me the records, and then we can send a follow-up email letter. And we've had quite a few patients actually want to sign the contract and put a down payment down at that initial visit when they haven't even met me. And I was a little taken aback at that, but I guess that is how the newer generation, they want to buy, and they want to buy today. So they're very excited to get in and get a scan and get started. So at our new patient consultation, when they actually come into the office, we look at what the wow factor is. And obviously our digital scanner is a big wow. And we do a scan on every new patient. And one of the powerful tools that I was surprised that made such a big impact is the occlusogram. When they see that their child's biting into their palate, or they see that they themselves have wear on their front teeth that corresponds with the red marks, it brings a different value other than they just have crooked teeth. They can see that damage is happening, and it brings a health value to getting the orthodontic care that they should have. So the treatment coordinator at your new patient appointment is incredibly important. And one of the things that we did was start coaching our TCs, okay? They need to know what cases you would treat with either aligners or braces so that you don't contradict each other. And then they also need to know how to proactively handle objections. So we go ahead and say right off the bat, Johnny will lose an aligner. but that's okay. We expect them to. But our increments of change in each aligner are so small that they can always go into the next one and it fits. So then the parent doesn't see that as a stumbling block. We also tell them that we're prepared to start whenever they're ready. So I know it used to be with our treatment coordinators, we had a couple that would always say, I know you'll want to go home and think about this. So we had to change the verbiage to, if you're ready to start, we're prepared whenever you are to get going. And the other thing we needed to do was make flexible payment plans. Most families are more concerned with the amount of the down payment and the monthly payments than they are in the overall treatment fee. And even if you have a plan where you charge a small amount of interest, the way consumers buy now, they want a small monthly payment, and how is it going to fit into the budget? Even if the overall treatment might be $200 or $300 more, they don't seem to care. It's more about the monthly payment. And the key monthly payment we've found is right around $175 a month. If it starts getting over $200 a month, they'll hesitate. But most patients, families, if you can get it under $200 a month, will start on the same day. And then if they don't start right away, then your follow-up strategy is really important. And again, I'm going to show you an example of what we do in a second. But at our clinical exam, we talk about the patient's lifestyle and how aligner therapy will not impact sports and things like that. We do our facial measurements. We ask about what they want to change, what their chief complaint is. And we talk about orthodontic and orthopedic needs. And I actually give them a mirror and have them show me what they don't like about their smile. Deep bites are a real a key factor with aligner therapy. When you show them a typodont with brackets on it and talk about the clearance for braces, they totally get the fact that they might be biting on them. So I think that it's a really important demo to do when you have a deep bite patient. And certainly we discuss how somebody that has a lot of restorative work, how it's harder to get the braces to stick on those kinds of teeth. And here is another powerful thing that we show during our new patient exam. We talk about the responsibilities between fixed appliances and removable aligner appliances. And we talk about taking the aligners off to brush and floss. And we actually have a little floss threader and floss and show them what they need to do with the brackets and wires. And if it's a child that's under about 10 years old, our TCs will usually say, and at least once a day, a parent will typically help with this. So we'll teach you how to do that when your braces are put on. And it surprised us that at that juncture, when a parent realizes what they might have to do to help, they will often go, now, what do we have to do with the removable trays? And they'll revisit that and they'll rethink that. Or you talk about the emergency visits and say, you know, if you have a brace that comes loose and it's pokey, we try to accommodate those kind of TLC appointments when we can. And when you bring it to their attention that that's a real possibility of that happening, then they start looking at aligner therapy with a more open mind. So for the one-step consult, in summary, kind of focus on what the lifestyle that they will have with Invisalign aligners versus fixed wires and brackets. I give them before and after pictures of patients that were treated like them. We have a demo on our computer that we have, you know, class 2 cases, before and afters, open bites, deep bites, things like that. And then make sure you take all your records so that you're ready to go and you don't have to back up and do that. and give them some customized options for their payment arrangements. So what I don't do, and I told you I'd tell you a little bit more, excuse me, about the what to do if they don't convert the same day. What we don't do is call them up and ask them if they're ready 3 or 4 times. So we call that dialing for dollars, and we don't do that. This is an example of the email letter that we send out, and we can certainly send it snail mail too, but most often people will let us send it via email. And we say how much we liked seeing them. We tell them again that we're ready to help them whenever they're ready to start. And we send a copy of the occlusogram and the before and after of the simulation. And most of our patients will call within that 2-week time period and tell us that they're ready to start. So then, following what happened with our practice, we started growing. And in 2016, we had to come up with what our next marketing strategy would be. And we looked at internal and external marketing and decided to do a little bit heavier in the social media. That's when we really dismantled our website, and we put on an even more user-friendly interface with electronic patient forms and things like that, because people really don't want to call your office and talk to anybody, and they don't want to come in and sit and fill out forms if they don't have to. And then we introduced a staff incentive program that was very simple. We had incentive bonuses in the past, but they were always based on formulas that the accountant helped us develop, and they were kind of complicated. And people didn't get the bonus till the end of the year. But we decided to implement something that was much more simple. So here's an example of what our bonus strategy that we started in 2016. Remember, in 2012, we had averaged about 57 starts a month. So when we did this bonus structure, we had started to grow, but not that much. We didn't really take off for us till probably mid to late 2015. So this bonus structure is incredibly simple. Depending on how many starts come in, let's say 70 starts came in for a month, they would get $100, every single staff member, right down to the sterilization person. Maybe prorated based on how many hours they worked, but from the top to the bottom, everybody got the same, which really cultivated a sense of teamwork in the whole office. And we threw in 100 starts at a $400 level. Never had seen that before, didn't think we'd ever make it, but we did. We actually went over our goal every single month, to the point that we had to invent some bonuses to make it even more fun and more interesting. So on top of meeting our 100 start goal each month, for the whole year, we had 290 starts on top of that. And if you look at what the charges on revenue that is, that's huge. So what that told us is, at least in our office, for bonuses to be effective, they have to be simple and they have to be paid out pretty quickly, because waiting to the end of the year, people lost interest. But if you pay it out every month, they see it as something tangible that they can earn, and it's real. So what happened in 2017, since they had made 100 every month, we raised the level a little bit, because that's a bonus should be something that you have to stretch for a little. And lo and behold, they did phenomenal with this as well. In the first quarter of 2017, we had averaged 150 starts each month. So now that we got our practice growing and we're starting to take momentum with this, it really started affecting our workflow. And one of the things that we needed to do was work even harder on our infrastructure. So what were we looking at with that? Well, I told you we needed phone training. And so from what we were doing in the office and helping our front desk, we felt we needed more professional help. So we looked at a group outside of dentistry because I didn't want somebody that was same old, because we had heard those different people over the years. And we actually found a group called New Patient Group who had worked in different industries before dentistry. And they took the principles from Starbucks and Ritz-Carlton and Disney and incorporated more of those philosophies in customer service and training staff on how to work with consumers than your average dental consultant. And so we hired them for our phone training. And then we developed different scheduling templates, and I'll show you what we use for aligners in a second. And then we decided to take on the Invisalign concierge appointments, because when you get to a certain level with aligner therapy, at a certain share of chair or volume, they start having patients inquire through the website of Invisalign for appointments, and then so they actually will call your office and schedule these patients. And we actually developed a way for the concierge scheduler from Invisalign to actually just go online and make the appointment. They don't even have to call our office. So that we incorporated with the online scheduling that we were already doing. And one of the things that we're still working on is implementing office texting for changing appointments and for scheduling and things like that. Because what we're finding is if people can avoid calling the office, that's really what they prefer. And this is the group that we were working on with the phone training, the New Patient Group, and they also help with getting in-office training videos for your different procedures and things like that. So here are our scheduling template changes. So for a full comprehensive treatment of Invisalign clear aligner treatment, we allow anywhere from 35 to 45 minutes for our consultation. We allow 45 minutes. Sometimes we get done a little quicker than that. Sometimes it takes a little bit longer, but that's about the time that it takes to take the photos, the X-ray, do the scan, and sit down and examine the patient. Then our second visit, we put attachments on. We start our elastics, and we give all the aligners to the patient. We have not had a problem with people taking off and never coming back. We just haven't run into that. We do put a sticker on every box that says don't go to the next box until it's been checked, because we may need to assess the fit, trim them, or scan for new aligners. So we kind of put a disclaimer on the box, and I don't know if that helps, but we really haven't had a problem with people not coming in. So they are in the office about 30 to 40 minutes, but they're really only in our treatment chair about a half an hour. And that half an hour is to put the attachments on. And we've moved our patient education portion of that away from the treatment chair. And we have a video that we made about wear and care of aligners. So they watch that even before they come back. And then they go to an area with a sink and practice with a non-licensed assistant, practice taking their aligners in and out and answering questions about, if they have any questions about wear and care and things like that. So we can get them out of the chair where we need to do, again, procedures that have to be in the treatment chair. And then we do 12-week fit and assessments and monitoring of compliance. And we changed our template for those visits to be 15 minutes. And typically they're in and out within 10 minutes. And then at about the fourth visit or so, we do a progress visit where we add taking photos to that so we can monitor and keep a record of their progress. And then we do a scan or a debond of aligners where we take their attachments off. And again, that's about 40 minutes. But we were having them come in for about an hour and a half because that's what we would take the time to take a fixed appliance debond. And when we started timing it, we found that they can take the attachments off and whatnot a lot faster than they can take the brackets off and things like that. So for phase 1 patients, it's very similar. And we do this the same thing. And one of the things I want to show you in a minute here is some phase 1 cases, so you can see where that untapped potential might be in your office as well. So that leads us to the last question: is the treatment as effective? And we, at this point, there wasn't anybody in our area really leading the pack with Invisalign Teen. And so we made that a big push. And here's just an example of the common cases that we do with Invisalign Teen that really set us apart. Here we have a young woman who hates her crooked tooth, okay? And she doesn't want braces. So when she smiles on her extraoral photos, you can see her crooked maxillary canine, and you can see that she's a pretty normal kid. You know, she doesn't have anything terribly exciting going on. She's maybe slightly class 2. But we have a diagnosis of class 1 dental with some narrow arches and some crowding. So our goals are to increase arch width, make room for the canine, and manage her erupting second molars. Okay, and we're going to use Invisalign and some IPR, some elastics, and we're going to get her wisdom teeth out. So, you know, these are cases to me now that are just bread and butter cases, because I much prefer to do a case like this with aligners than with brackets and wires. Not a difficult case. Okay. The key in this case really is making sure there's no collision around that canine and that you widen it before you start to bring it in. Simple. Okay, so in 9 months, she's looking fantastic. Okay, that canine still needs a little tweak, but she's very happy that it's come down. And in 12 more trays, uh, and I do weekly changes, so that's 12 more weeks. We've got her issue resolved and she's settled in nicely. Okay, that is a true practice differentiator. Okay, so you get the reputation for doing that and people start coming to your office. Okay, and that's not even difficult to do. We probably saw her for 4 appointments. Okay, so this is what happened to our practice. We were seeing about 600 cases a year, and we've more than doubled that now. And it didn't come at the expense of our fixed cases, okay? Because this is fixed and aligners all together in 2012 and 2013. And if you notice in 2016, our fixed cases are as much as our fixed and aligners combined. So not only getting a reputation for being an office that does Invisalign help you bring in that group of clientele, it also brings in more fixed patients as well. So I saw it as a total win-win. And this is just what we're doing now in 2018. I threw this together the other day because we just finished August, just to show you we were averaging about 50 starts a month in 2012 and 2013. And we've grown really, really strongly. So take advantage, and when you get to a higher level with Invisalign and they start actually giving you leads on patients, and I, for one, am not threatened by the Invisalign stores coming into the areas. I have friends in San Francisco that are orthodontists that say that they get 1 or 2 new patients a week from the store. Those stores seem to be driving patients into the orthodontist offices. So I don't see that as a threat. And I actually wish they'd put one in the Twin Cities.
Regina, can I
Yeah.
ask a quick question? So I've got a question from somebody basically saying, in this day and age, what are you doing to specifically compete with Smile Direct Club, Invisalign stores? He says, I'm not. Oh, just one more
Go
bit.
ahead.
I'm finding that when I present my normal Invisalign fee to an adult patient with relapse, they're reluctant to pay $5,000 to $6,000. They have options at $2,000 to $2,500.
Yeah. Well, first of all, I'm not threatened by the Invisalign stores or the idea of them. But one of the things that we had to kind of take a deep breath and step back is when, and I actually had one come in today, because it happens daily now, that someone will come in and they, like you said, they've stopped wearing their retainers, they've got some mild relapse, and we actually offer now an option that we call limited treatment Invisalign. And so we tell them that they can have 20 trays, and it's about $3,000, okay, $29.95 or whatever. And we'll do up to 20 trays with some attachments and IPR. And if they're not happy after 20 trays, they can either they can use that and upgrade to full. So that's our competition with like a Smile Direct Club. It's doctor supervised. They get their assessment appointments. And here we at least are making them better. And if they choose to stop at the limited and they're happy, great. But they know up front at that point we're done unless they want to upgrade to full.
Okay, a question.
Any follow-up question on that?
Yeah, I've got a couple follow-ups. Do they then pay the full fee?
They just keep making the monthly payment, yes, up to the full fee.
And would you just present Invisalign Lite to them?
I don't, at my discount level, use any of the products except comprehensive, because I don't want my hands tied really to what I do. And I'm paying at my discount level, I'm only paying about $800 lab fee. So some of those other options probably don't make a lot of sense for me to do. And we just accept that as that's our fee. But I'm only seeing those limited treatment patients maybe 3 times. Your consultation, your delivery, and then your mid-treatment assessment and your finish. So counting the new patient exam, I see them 4 times. So it's not bad.
Mm-hmm. Okay.
The next thing that we're capitalizing on at our office, where there's some untapped growth potential, is being known in our area for doing Invisalign on our phase 1 patients. And here's what you get when you use Invisalign first. You have what we call an expansion option that's a little different than you get with a regular Invisalign. where they will move the molars first. For example, if you have a unilateral crossbite and you want to move the molars wider and use those as anchors to expand the rest of the arch, you can get that with Invisalign first. You can also get attachments that grow larger the smaller the tooth is. So let me say that again. You get a bigger attachment on a shorter crown tooth so that you have better retention on primary teeth. Okay. And then they have certain algorithms for the speed of movement of the teeth and things that are particular for Invisalign first. The other thing that you get are eruption compensation wells for the anterior teeth. And that comes in handy. So if you have an erupting lateral incisor, say, you don't have to rescan because the tooth will typically come down pretty close to where that eruption compensation is. Now, sometimes it'll come in near the edge, and we just take an acrylic burr and buzz that down. So here, let me just show you this. Here is the molar moves first. So the molars move out, they hold the anchorage, and then the rest of the arch develops. Or if you have a case and there's not a crossbite or you don't feel like you need that extra anchorage, you can do simultaneous expansion, and that works as well. So you have both of those options. And then these retention attachments also, you can see they're kind of half circle attachments, and the shorter the clinical crown, the bigger they scale based on the tooth size. Now, if you do Invisalign first, you have to upgrade your ClinCheck software. So if you are already on 5.4, you'll get it automatically, or you did get it automatically. If you're at 5.0 or earlier, you actually have to go in and do an upgrade manually. So here's the cases that opened my eyes to this. When I agreed to be in the limited market release, I had done some phase ones, but once it was a study and they had this product and asked me to do it, we started looking at, could this be another area of potential growth for us? And we started doing quite a bit more. And I'm just going to show you a few examples of what this can do. So if you have someone like Pearl who's crowded and she's been to other orthodontists and they want to extract teeth or they want to do a jaw expander, parents, those aren't practice builders. They may be effective, but if there's something gentler and more consumer friendly, people are going to seek you out once they know that you offer an alternative. This was a great kid. She came in and you can see she's very deep. Okay. So in the past, what I might have offered Pearl was an expander and maybe a Holly with a bite plate, maybe 2x4 appliance to procline her teeth, but it involved a lot of hardware. Okay, so when she's in a mixed dentition, she's a little class 2, she's narrow and she's deep. We see these things all the time. She's got blacked out canines. So what we want to do is some dental alveolar development and try to resolve her crowding. And so she was part of the limited market release, and we know we're going to do a phase 2. But here's what her ClinCheck looked like. Okay, really pretty simple. We're proclining teeth, we're widening the posterior arch, and making room for canines. It's not hard. Okay, actually very simple. And I'll show you where we got in 40 weeks. So you can see the retention attachments, And the retention attachments did a great job bringing the molar back and socking it in. And then the plastic pushing the anterior teeth forward acted very much like a coil spring and opening up space for those canines. Okay. So one of the things that I want to caution you if you start doing Invisalign first is always watch for your molar rotation. That'll help you correct your class 2. And when you put a bracket on a tooth like this and put a wire in, it automatically rotates the tooth for you, not necessarily with the liner. So one thing to watch for, okay, is your molar rotation. But here she is at 12 months when we're done. And we've got our class 1 molar now, and we have our space open for our canines, and you can see them even coming in. And here's another little guy, and he's crowded. And they had been to another orthodontist that wanted to pull out teeth and had even talked about him needing 4 bicuspids out. They were already talking about that already with him. So here we go. This is what you see. He's severely crowded, okay? I won't argue with that. And if you look on his x-ray, you can see the crowding in the canine area, and especially down here, we've got a cuspid coming in underneath of a lateral incisor, okay? So middle mixed dentition, he's class 1, incredibly narrow, deep, severe crowding, and he's got an ectopic 22. Again, you know, we're just doing some dental alveolar expansion to resolve his crowding, and we're going to use Invisalign first. We're going to do some sequential molar expansion. This is one that's narrow enough that I wanted to move the molars first. And one of the keys here is keeping the lateral roots in control and not tipping them out into where the canines are. So, you know, here he is with his ClinCheck. Let me start that. Okay. So the molars are moving out first, then the mid-arch widens. We bring the laterals forward. Okay. So again, 35, 40 weeks. And here he is at 3 months. You can see it starting to happen. Here he is at 6 months. See the arch form change and the crowding resolving. Here he is at 9 months. Okay. We still have the issue of the one canine coming in under the lateral. But here you have someone that now probably, if anything, might just need a central incisor out, not 4 bicuspids. And remember, they came in because they were freaked out that he was going to have any permanent teeth pulled out. And let's just go back. You know, this is looking much less scary to the parents than when he came in the first time. And just to show you one more, here is Benedict, and he is missing, I think, oh, he has a deep bite and he's getting wear on his teeth. And so we talked about the benefits of Invisalign covering the incisal edges and the difference between that and him maybe biting on brackets. So one of the things you can see, he's got some vertical maxillary excess as well, and he's very deep. And you can see the wear he's already got on his upper centrals and his lower central incisors. And you can appreciate the crowding. But notice I'm treating him even though he's already started exfoliating some teeth. Okay. So how do you handle that? And actually, that's really easy. But his diagnosis is he's a clincher. He's class 2 div 2. He's got the vertical maxillary excess. He's narrow. He's impinging and he's crowded. So we're going to widen his arches and improve his overbite and overjet. How? We're going to use aligners. But one of the key things is for him, we can control where the lateral incisor roots go. And again, we're going to use sequential molar expansion. And I'm going to add class 2 elastics for Benedict. And some distalization and bite ramps. So here in one product, you can run your rubber bands, you can have your bite plate effect, and your brackets, all with the aligners. Okay, so we can keep the mesial inclination on the laterals for as long as we deem necessary. We can work on the upper anterior intrusion for the vertical maxillary excess. Okay. We're running our class 2 elastics. We've got our distalization for our class 2 correction. Think Pendex type reaction. Okay. And these little empty wells where teeth are missing, the eruption compensation areas, I just leave them. I don't do anything with them at all. Okay. Again, on this side, we've got molar rotation and distalization. So you get the idea. And the keys here, again, controlling the roots of the laterals so they don't drive them into the canines. You've got your molar rotation to help with your AP and your bite plate effect with your bite ramps. And here he is at 6 months. The vertical maxillary excess is looking better already. Now he wanted colors, so we put his attachments on with colored pedo composite. So there's even an option for doing things like that. So that is the end of the formal. I'm sorry, I went about 15 minutes over, but the pedo product, I tell you, I'm super excited about it because I think it's just a huge area of differentiation potential for practices out there. Because when you start treating these younger kiddos with things that are comfortable and allows them to still enjoy the things that they like for being a kid, like going to the state fair and eating all the junk food and not having to run to the orthodontist office because they ate something that popped 3 brackets off. You start getting a reputation, and we're seeing parents come in now and the word of mouth of, well, we heard about you and that you can treat the younger ones with the aligners. We're hearing that now every day. And like I said, we're starting to grow so fast that we're having growing pains. But it's a good problem to have. So.
Regina, thank you so much. You've been amazing. We really appreciate you, staying with us. And basically, just because of time, I'd like to see if anybody else has, we've probably got time for 2 more questions. If anybody else would like to ask.
I think everybody's sleepy.
No, I think they're awake for you.
I know Glenn said it was a great group, very casual. I feel like we kind of sat down and had a one-sided fireside chat. But let me just throw out the invitation that I can give you my email address, dr.blevins@minnesotaorthodontics.com, and if you have any questions, follow-up questions, I'm more than happy to share. I'm all about trying to take this profession that we're so blessed to be in to the next level. And I would like to see, well, I hesitate to say this, but I'm going to say it anyway. I'd like to see SDC do what I'm doing with the phase 1 patients, and hopefully they won't get in that market. But it's a really an exciting and a tremendous thing to be able to offer these patients what we're doing now.
I've got a question here for you. In the case of the 11 and a half year old boy who had teeth erupting, did you start with Invisalign first and then move into phase 2 Invisalign, or did you start with Invisalign teen or full?
He was part of the limited market release, so he started with an Invisalign first. And right now he's in retention and not ready for phase 2 yet. These cases are fresh off the press, okay? Because the limited market release of Invisalign first was only about, I'd say, a year and 8 months ago or so. So, you know, these kiddos aren't ready for phase 2 yet. But now he's actually, I think, technically under a teen treatment because they didn't have the phase 1, phase 2 pricing when they did the limited market release, if that makes sense. And one of the questions that comes up is, why would you ever do the phase 1, phase 2 when you could get 5 years with the comprehensive? Well, if you start someone at 8 or 9 years old, it's a little tricky sometimes to get them done in 5 years. That's one issue. And 2, you don't get the molar anchorage expansion. You don't get the scalable attachments, and you don't have eruption compensations for the anterior teeth. So you really have to weigh those what I see as pretty valuable assets against you know, the difference in doing a phase 1, phase 2 and a comprehensive. And again, at my price point level, the difference between phase 1, phase 2 and just doing a comprehensive is about $300. So it's not a huge cost difference once you get up into the higher discount tiers.
Great. Well, I think that'll do it for us. So everyone can go back and listen to it again. It's been recorded. We'll post it. And we just really thank you very much for your time.
Oh, you're welcome. You guys have a great evening wherever you are. And again, don't hesitate to reach out if you have other questions. I might not get back to you the same day, but I try to get back within a couple of days. So good evening, and fight the good fight, right?
Thanks, Regina. Have a good night, everyone.
Mm.
Bye.
Bye.